Honorable Pukose and Mr. Gibore. Let me just bring in Wambui. Mitine, now, the issue of means testing instrument is a big concern. And when you're in the informal sector, you're supposed to key in what you have, and then you'll be given the amount that you are supposed to pay. Yeah. This is a very questionable method. And let me just rope you in as well. Honorable Pukose said that the committee did not agree with the ministry's decision to involve only 2,000 people in their pilot across the country. That number is very, very small. I don't know, from where you sit, what should be the alternative to this means testing instrument? Because it is proving to be a big mess, because it is not only a big mess in the health sector, but also in the university funding model. So how do we come up with a different, can we come up with a different way of, knowing the amount that people will pay?
I think the thing is, we should localize our solutions, because when you look at the means testing kit and the tool, it looks like it's completely imported. And I was mentioning to the panelists earlier that when you're from Mashinani, you say that you have a piece of land and you have a house. So that means like you're a homeowner already, and you have cows and you have all these things. So they're considered as assets, as opposed to they're just your things that you deal with, So when you look at the issues that we are dealing with right now, someone in Turkana right now will be asked to pay 6,000 a month. Someone in Kiambu, Githongori, and they probably just have one cow, they live in ancestral land, all of the brothers and sisters, they all live in the same parcel of land, but they are all considered homeowners and landowners. They'll be paying the same 6,000. And someone in Turkana again will have probably a cow or 2 cows. So the means testing kit definitely is imported. It's not a local solution, and it's not a local thing for Kenya. So I think the ministry and parliament, the health committee, should go back to the drawing board. When you look at section 26, it requires for you to register using a form. So that particular form, the way NHIF was doing it, you can just go to your local Huduma center and you key in all those things, because in Moranga, as the deputy governor is saying, when they do the sensitization and the 40,000 people who've registered, they will know. So you'll know that this person has been told to pay 1,200. They can't even afford the 500. The 300 will be a stretch, and they are willing to pay that 300, but they can't even afford it, but they are willing to pay it. So when it's done in county level, because again, health is a devolved function when you look at it. So it should be at county level, and when you tell people to go online, to register, to have a QR code and all those things, and when you look at the percentage of Kenyans who actually own smartphones, it also does not, the math is not mathing the way the Gen Zs were saying it. So when you look at all these things put together, it should have, again, I'll say it should be a localized solution, because the social health care fund is a good thing. The universal health coverage is actually a really good thing if implemented the way it should work and the way it should. And also maybe I should just mention on the primary health care. When you look at the system, it's a referral system from level 1, 2, 3, then you're referred to 4, 5, 6. The bulk of the money is actually going to the primary health, the deductions, the 2.75%, they're going to the level 4, 5, and 6. And I think it should be the inverse, because all Kenyans will be going to level 1, 2, and 3, and then they're referred to level 4, 5, and 6. But in this situation now, the bulk of the money is given to 4, 5, and 6. So again, I think also the health committee should look at that, or trickle more money to the primary health care fund as opposed to the social health insurance fund, because in that way, more Kenyans will be served and more money will be where people will be accessing health care, as opposed to 4, 5, and 6, which will be the referral system.
Now, fair enough. Mr. Gibore, let me come. There's the issue of registration, but let's just move away from that for a moment. Now, those patients suffering from chronic illnesses, we've seen patients who need dialysis, who need to undergo chemotherapy and all that. And you talked about the issue of the government refunding. Now, the private institutions, because most of these patients do go to private institutions, and the private institutions are not only decrying about the issue of the challenges being faced in this particular system and how they cannot provide services until people pay in cash. But also there's the issue of, the debt accrued under NHIF, and it's around 30 billion. The government said it had released around 9 billion. But these institutions and stakeholders do want that particular debt fully cleared before we transition to SHIF. I don't know from where you sit. How can we sort out that problem?
These are some of the messes that we create as public officers, and why I'm saying that, as healthcare providers, we are pro-life, and any system that wish to support the health system must demonstrate being pro-life. Now, if at all I offer services that expect payment, and more specifically from a government institution, and you don't pay, what you are meaning, you are pushing me to offer services that do not meet the standards. And that's what the private sector are trying to say. Please do your work. You actually got into an agreement for us to do these services. We did it. You're not questioning. Please pay. Unfortunately, what we are also not being told is that there are money deducted from source, that's from employees, and are never sent, or rather transmitted to NHIF. They were never transmitted. And the major culprits are counties. There are some counties that up to closure of NHIF, they still owe billions to NHIF. So if that money had been remitted in time, then that's to mean we'll not be having these issues that we are talking about. And when you look at the money that we still owe NHIF still owe service providers, you also think about the corruption that is involved in that institution, which was the major contributing factor to why Kenya was not trusting NHIF. So if then during this transition period, the biggest question we normally ask, what mechanism then have we put in place to ensure that there will be no more corruption in the money that is intended to offer services? Anyone will be talking about the digital health pathway that we have now established. Mm-hmm. But I always say the system is as good as the person who manages it. So have we cleaned? What kind of moral have we changed alongside those the whole institution, so that then we are able to win the public trust? And I must call it in order that we always talk about Gibore have been involved in corruption, okay, but they have never been end-to-end case. Geoffrey Mwangi was the CEO, was accused of several billions. He was vindicated. We know that since last year to this year, we have talked about losing several billions. No one has been actually taken to account in terms of the money we lose. So how do we say there is trust? And again, as we talk about this, there is clear provision under the Social Health Act in terms of what should have been put in place for it to start operating. As we talk today, the S.H.A has not employed any worker. They are still using seconded people, and there was no provision for seconded people who are working under S.H.A. And there is no policy up to date. So where is accountability in terms of what the government ought to be doing? Do it fast and demonstrate, work with people. And we must call for transparency, accountability for any public officer who wants us to trust any institution. Okay. And that is the biggest thing that we are talking about. And allow me just to mention that thing called the mean testing tool. To date, the major practitioners, healthcare workers, whether private, faith-based, public, it is a medical, I think I need to refer it as a terminology that no one really can explain about it, okay, including most of the legislators, even in the health sector, okay, I mean the health committee. And that is what we are saying. So who understand this thing that we are implementing? Fair enough. So that then we know, we have predictability where we are and where we need to go. I have seen several responses from government officers who are from the ministry, who are supposed to be the drivers. They still answer same question in different ways, the way they want.
Pretty much. Let me engage you, Honorable Mburu, because the issue of these patients who are suffering from chronic illnesses, I don't know how county governments are dealing with this. Mr. Gibore has attributed the issue of pending bills, and I think county governments do around 12 billion. Now, we are reporting around 44,000 new cases of cancer every year, and we're reporting around 29,000 deaths. By 2028, it is estimated that we'll be having around 58,000 a year. That is in terms of cases of cancer. As a county government, how are you, ensuring that even amidst all this mess, these patients who are suffering from cases like diseases like cancer, get assistance? Because in some instances, probably late discoveries, they require timely access to health services. And if at all they cannot access those services because of the mess that we're witnessing, then it's like, you're just there sitting, waiting to...
Thank you very much. I think we need to be as innovative with solutions for the purpose of the public as we can be. And I want to mention on 3 categories, and especially from where I sit in Murang'a County Government, how we have tried to deal with issues, not only the issues that arise with providing care, but also providing services that are affordable to the people and closer to the people, on issues of chronic illnesses and issues that you have mentioned on issues of dialysis. I'm just going to give an example of what we have done in Murang'a, because I cannot speak for all county governments. In Murang'a, we have taken 4 steps. Number 1, we have, for example, in the area of dialysis, we have partnered with partners such as Benacare, and we have established 2 dialysis centers, at least one in Kigumo Level 4 Hospital and another one in Murang'a Level 5 Hospital. We have equipped at least one, the Murang'a Level 5 Hospital, now it has 12 machines, and the one in Kigumo Level 4 Hospital has 10 machines. That is each now providing approximately 60 sessions every week for those people needing dialysis care. The second step we have done is ensuring that we utilize our digital process for the purpose of telemedicine for the people with chronic illnesses and issues that they require to get to the hospitals on a daily basis. We did telemedicine with partners such as HealthX, and what we were able to do is bring partners on board who not only have the technology but also have the resources. What we did as a county is to be able to support them in terms of the infrastructure and also the medical practitioners who are supposed to go towards that. Now we have telemedicine in 35 primary healthcare centers that are level 3 facilities that are now providing care to 15,000 people with chronic illnesses. Such innovations have helped us to continue providing services. The third innovation that we have done as a county government is ensuring that our Kangata Care platform is catering for these patients not only within the areas that they require within public facilities, but also within the private sector. Right now we have a partnership with Britam that ensures that not only do we provide services at the primary health care at the level 4 facilities, but we also provide other services such as last expense using now Britam. We provide now a last expense of 100,000. We also give a delivery, the delivery of children within our public hospitals through certain amounts, so that we can be able to bring everybody on board when it comes to providing services to the people.
Fair enough. Let me come to you, Honorable Pukose. Mitine did talk about the issue of contribution and the services being commensurate. That is one of the biggest concerns, because some people are talking about the money I'm contributing is not directly proportional to the services that I will get. And Mr. Gibore said, the PS for Medical Services, Mr. Harry Kimtai, did say, if at all, he said this is not an issue of you getting services which is commensurate to the money that you pay. It's about standard provision of services, health services to all Kenyans. But the question is, if I'm contributing 10,000 and then at the end of the day I'm only given services worth 1,000 bob, where's the value for my money?
Thank you. And when Wambui raised about the services that were being offered under NHIF, and now we've moved into S.H.A, which has Chief Primary Health Care and Emergency Chronic and Critical Care Fund. This is an improvement. And one of it is that we should look at it as a social health insurance. It covers for everybody, so that for those who have, pay for those who don't have, so that everybody is brought on board. when you look at the services, you can say that, for example, dental, maybe the amount is around 1,000 per family. Then optical, dental is about 2,000 per family, optical about maybe 1,000 per family. When you go back and look at the NHIF, what was it offering? These were not there. This is an improvement. When you look at even issues about renal, you have, when you exhaust your SHIF, you can access now the emergency, chronic, and critical funds. So that was not there.
For the civil servant, those who are in formal employment, they had a clear, those are for the new.
I'll come to that.
Yes.
That was not there. When you look at, even in terms of the system that Kibore talked about, initially, NHIF had about 12 million contributors. When this system was linked now to the National Registration Bureau, it cleaned up, and 9 million people are now the ones who are transitioned into S.H.A.
Okay.
Then you ask yourself, these other 3 million, whom we are being told that these were, their data is missing, or their details are missing, and yet these people have been accessing services. So you ask yourself, who are these 3 million?
Okay.
Then in terms of linking up to the system, one of the things is that it links up to all the professional bodies, including the Clinical Officers Council, including the Pharmacy and Poisons Board, so that any medication that is coming into this country,
okay,
it has a patch number.
Okay.
You can do track and trace of that medication. So that if I'm dispensing it in my clinic and it's a generic, I should not charge for an original.
Okay.
It also fits into, the system fits also into the professionals.
Okay.
Whether it is the medical practitioners and dentists council, whether it's physiotherapists, and that is able, you are able to identify that.
Thank you very much, Honorable
Just to
Kokose.
answer into the question about
whether
it is commensurate or not. You know, at times we pay for our insurance for our vehicles. If I have a Mercedes, I'll pay a higher premium. If you have a Probox, you'll pay a lower premium. But that does not mean that I should be able to knock my car against and cause an accident,
okay,
just to claim.
Fair enough.
So why should
our bodies, as much as many of us might pay a certain amount of money, but we wish to be healthy. Okay. You will always try to be healthy, and so that the other person can benefit from what I've contributed.
Fair enough. Because of time, let me just briefly, guys. Wambui Mitine, the government has set aside under the primary healthcare fund, everybody will be according 900 shillings per year. We have around 51 million people. The national estimated cost will be 46.3 billion. The only allocation that has been given so far is 4.1 billion. That is less than 10%. How can we deal with that? And what is the way forward? Briefly.
We don't expect all the 51 million people to see.
Kindly,
I think
kindly.
First of all, I think maybe I can just what Honorable Kokose said on dental and optical. If any of us, I mean, if you wear glasses and all that, if you went before to hospital and then you claimed an NHIF, you would have gotten even. And this is not only for civil servants, and you had probably a procedure, dental or optical, it would have been covered, a percentage would have been covered by NHIF. So I know he's saying that ideally it's an improvement, and when you said it's an improvement and then you're capping it at 1,000 or at 2,000, I'm wondering, is it really an improvement? But now, when now you talk about the primary,
let her finish.
When you talk about the primary health care and what has been put aside, I think again it needs to be ratio based. They need to look at exactly what is there and how many people are deserving of this healthcare, because again, under the Constitution, Article 43, health is a right. It's a right. It's not, I don't need to have a registration form to get that particular right.
Thank you very much. I think it would be unfair if I leave you, Mr. Gibore and Honorable Mburu, 20 seconds kindly.
20 seconds, what I say is that the law is good, the aspiration therein are good, the implementation are casting aspersions, and it must be cleared. And one thing I know is that there are mandatory provision under the Social Health Authority Act, and it must be done, starting from the government. Let the government start first. Let not push individual to do it. including when you say everyone will be a paid-up member. There are those who are not going to pay, called the indigent. The government is supposed to pay for them. Ask the government whether they have paid for anyone up to date. Okay. So that is on the payment on the SHIF side. Leave alone the Primary Health Act where everyone is supposed to get a service. But I'm also, those who are getting a superior cover should not be relegated, should not be reduced.
Thank you.
Thank you.
Honorable Mburu, finally.
Thank you. I want to conclude by encouraging the people of Murang'a, everybody who we have provided for with the Kangata Care, to turn up for the S.H.A testing, so that we can be able to determine the value. For the next 16 days, we are going to have this campaign across all wards, across all sub-counties. I also want to thank the Africa Association for Public Administration for nominating Kangata Care as one of the most innovative public policies across the continent. They are going to award us with this innovation in Kampala on 28th of this month.
Thank you.
We do thank them for considering Kangata Care as one of those innovations.
And my 20 seconds.
Okay. Kindly. 20, Honorable Pukose.
Okay, thank you. And what I want to assure Kenyans is that as a committee, we'll be able to make sure that this, especially the proxy mini testing, is properly done and localized, so that nobody is left out from this care. And the government, and will also be able to look at the budgetary allocation for the indigents to make sure that the indigents are not left out.
Let me say that
because of time, we cannot continue.
It has worked in Ghana and it has worked in several other countries, but we are getting it wrong in our country.
Wambui, thank you very much for making time. That was the conversation surrounding the Social Health Insurance Fund and the transition from NHIF. I think we need to find more time to deliberate more on this particular issue, but that is all that we had for you up to this particular moment in time. Remy Majala will be coming to you in a few with the Morning Vibe. Do have yourself a wonderful day, and like always, God bless.